Okay, we're addressing foot and ankle pain that you may have had for a long period of time. If it's greater than 8 weeks, 3 months, a year, 5 years, you got to start looking somewhere else and identify what the true problem is, the thing that's preventing you from being yourself again. It's important to understand that the musculoskeletal injury that you had, whether it's an ankle fracture or an ankle sprain, fracture to the foot, these conditions all take approximately about 8 weeks to heal at most. And if you are still suffering from problems, we know that there's another condition happening. Before I tell you what that other problem is, my name is Dr. Richard Loninger. I'm a foot and ankle surgeon in Manhattan, New York for the last 29 years. And this video is entirely educational. It is not meant to supplant the proper patient-doctor relationship. So let's get into the secondary problem that you're suffering from. It's not just musculoskeletal, again, because musculoskeletal improves dramatically, rapidly, from point A to point B very quickly. If you're still suffering 8 weeks out, months out, years out, it's a nerve problem. It's that simple. It's a nerve problem. Nerve problem is going to be appreciated when you see things like numbness, tingling, pins and needles, burning, shooting sensations, cramping, pain at rest, pain at night. Neurological hallmarks. Those are the pathognomonic markers of nerve inflammation. They don't occur with any other system. They don't occur with the musculoskeletal system. So it's definitive. Another way of determining it is just simply palpating the nerves of the lower extremity, which I often do. These nerve problems persist because they don't have the ability of the musculoskeletal system with its innate ability to heal. On the contrary, they have two pathophysiological features that will cause them to get worse and worse and worse, and allow for them to not get any better. One feature is a nerve becomes hypertrophied and enlarged. When it becomes enlarged, it's very sensitive. It will get compressed and squeezed, especially in the lower extremity, in the fascial planes. As it gets squeezed, it gets further enlarged, further irritated, further hypersensitive. In addition, we have what are called sodium-potassium ATPase gates that are left ajar and open. In a normal state, gates are closed. When we appreciate something painful, we move our hand. What just happened is these gates opened up. They allowed ions to go in and out. And it told my brain to tell my arm to remove itself from that impulse. And it did so in a nanosecond, and then they fired shut. In somebody with nerve pain, the gates are like this. So the nerve, when it's injured and traumatized, it causes direct pain to the lower extremity. It causes a hypersensitivity to that musculoskeletal event that occurred. But in addition to that, it also contributes its own pain to the region in which it was just insulted, which is the lower extremity. But now the basis of this, the origin of this, is a little more intricate, and you've got to get to the basis. You've got to get to the foundation of this problem. I just had a patient who just sustained an injury. A gate in the back of a bus dropped on her, a lift gate, dropped on her foot 5 years ago. She's been in pain for 5 years. She did explain to me, as I asked her, she explained that she does have a back problem. She had a back problem for a long period of time. So now in her, what we expect is that back problem created a mild impingement to some of the neurological structures to the lower extremity, creating a reverberation. No such thing as one nerve that's aggravated. It's one big electrical grid. It's like a spider's web. Any insult anywhere in that web, the whole system feels it and reverberates it. So if there's an insult at the spine, the whole system feels it. Our lower extremity in particular is stolen from. It's not very well taken care of with circulation and immunity and things of that nature. So the nerves are more susceptible to the lower extremity than they are even of the upper extremity. But that back problem that she sustained a long period of time created this excitation or this inflammation of the lower extremity nerves. Now she traumatized the extremity, traumatized her nerves, traumatized the musculoskeletal system. Musculoskeletal system fell out of the equation 6 to 8 weeks later, 12 weeks later maximum. It left her with a nerve problem. And those two pathophysiological features starting exhibiting its nature. And this is why she's not getting better. So in you, there could just be a lower extremity nerve problem, but in all likelihood, there's probably a back problem that's associated with this. I find that there's a back problem in just about everybody who presents in this manner. Sometimes the back is severe, sometimes it's moderate, and sometimes it's mild. And even more difficult is the patient that tells me that their back is perfect. But I know that I must treat the spinal cord with the nerves of the lower extremity down here in order to resolve this entity entirely. So what we do is, first of all, it's like two fires. fire in the lower extremity and fire at the spine. The neurological system is an electrical grid. It's like a cord, an electrical cord. It's propagating an impulse down that line. If there's a fire in the lower extremity, we just put that fire out of the nerve structure down here in the lower extremity. We're going to make the patient significantly better. But the pain is likely to return again if we're leaving the fire at the spinal cord. You need to take care of both fires at the same time. What we do with the spinal cord is we institute exercises that are going to restore proper curvatures back to the spine, that are particular for this patient's problem. In the lower extremity, what we do is we call her in on a Friday. She gets a little medicine in her arm. She's awake, conscious, she's talking, but she feels sedated. And I'm administering medicine that's an anti-inflammatory. An anti-inflammatory is going to shrink that nerve relatively by 1/100th of a millimeter. If it shrinks a little bit, it's going to exhibit some relief. With some relief, it shrinks further, and so on and so forth. I close those pain gates. In the patient with nerve problems, the gates are left ajar. I close them by delivering a local anesthetic. Local anesthetic, same medication that your dentist uses before he does any work on your mouth. So by closing those gates for an hour and a half, which is how long the medicine takes before it wears off, we're reestablishing those communications with those nerves. After I'm done with that, it takes me about 3, 4, 5 minutes to do. After I'm done with that, it's like a light switch. The next day is like a light switch. That pain that you had for all those months or years is gone. But we need to commit to the back exercises forever. This is how I resolve this entity in my practice when I have a personalized relationship with my patients. You're more than welcome to look me up. You're more than welcome to have a telemed appointment, or you're more than welcome to purchase that 5-point educational protocol that's going to help you at home. It's going to include those exercises for your back, a device that goes in your shoes. That's about $18. It's better than an arch support for this. I give you nutritional support. I give you a physical therapy modality that's going to help with the foot and ankle inflammation to the nerve. And I give you a template for your doctor that I want you to review with him that's going to explain the medications that work on this nerve problem, not the ibuprofens, Motrins, Advils, Aleve. They don't work. So it was nice speaking with you today. I hope to see you again.